Hi, everybody. Welcome to our Bullet Points Lunchtime webinar series on fire injury prevention for clinicians. I'll start the intro while we're waiting for some more folks to sign on because I know it's just at the top of the hour. I'm Dr. Amy Barnhorst, and I'm going to be moderating today's session, and we're really excited to have Nerisha Harris, Chevist Johnson, and Esmeralda Huerta, who are violence intervention specialists here at UC Davis. They work with the Wraparound Trauma Prevention Program, and they're going to be talking about their experience with hospital-based violence intervention programs, which are a really important part of multidisciplinary care for people who've been violently injured. So a couple announcements to start with. We do not have a webinar in December because of the holidays, so look out for an email announcement about our next webinar, which will be happening in January. The time will be the same in the new year, so mark your calendars. It's every third Thursday of the month at noon Pacific time, just for 30 minutes, and you can sit and eat your lunch and listen and learn. And also as a reminder for those who have been with us before, you know this, we're going to have a poll at the beginning and at the end of every webinar. They're super short, and they help us understand where everybody's coming from, what you already know, and what you're interested in learning, and what you do learn from our webinars. So it helps us kind of craft our content and seek out new speakers. And there's a question on this poll that asks you about your profession, and one of the options is other profession. We found that there's a lot of people choosing other. So we were hoping that today folks who choose other for their profession could write what their specific profession is in the chat. And actually, I think it has to go in the Q&A because the chat function is disabled. So go ahead and put your specific profession in the Q&A, and that'll help our evaluation. So we're going to launch the opening poll now, and it will take a minute or so. Oh, it looks like the chat is working. Okay, great. Sorry. Put your profession in the chat. That way everyone can see it. It's kind of interesting to see who's here. And we will open the poll now. And once the poll is finished, I'll go through and introduce our panelists for today and what they're going to talk about. Okay, great. Thanks for completing that, everybody. And we're going to save most of those until the end, and then we'll have some time for discussion. But without further delay, I want to introduce Nerisha Harris, Chevist Johnson, and Esmeralda Huerta, the violence intervention specialists at UC Davis Wraparound Trauma Prevention Program. Mrs. Harris is an associate marriage and family therapist and has extensive training providing trauma-informed support, case management, and mental health services to those that need it the most. Mr. Johnson is a certified gang intervention specialist with over 15 years of experience working with both victims and perpetrators of violent crime. And Mrs. Huerta, a certified violence prevention professional, partners closely with community agencies in Sacramento and provides comprehensive case management to violently injured young people. Their experience and awareness brings empathy, courage, and mentorship to victims of violence in their steps to recovery. They seek to provide trauma-informed counseling, tools for resilience, and advocacy to support victims in their leaving traumatic lifestyles behind in the hopes of discovering a new direction in life. I'm really excited to hear this talk because I think that for many of us, hospital-based violence intervention programs are something we don't have a lot of contact or experience with, but they are a really important part of the bedrock of helping injured patients get into a healthy lifestyle when they leave the hospital. So thank you so much for being here, panelists, and I will hand it over to you.
Thank you for that, Amy. And hi, everybody. We're going to go ahead and share a quick video, and then we'll get started.
Hi, my name is Esmeralda Huerta. Hi, I'm Nerisha Harris.
My name is Chevist Johnson.
The Wraparound program is a free service for patients between the ages of 13 to 26 years of age who were injured by community violence. The program provides support for patients who have left the hospital but are still recovering from their injuries.
As intervention specialists, we provide intensive case management to help patients injured by violence with healing mentally and emotionally, while also helping them find hope and purpose.
The Wraparound program can connect you with community resources for the day-to-day needs. When link you to mental health services to help you with your recovery, mentor you on safety planning, life skills, and goal setting, help you get back on track with education and employment, while also assisting you with legal paperwork related to your injury.
I am very grateful for the Wraparound prevention program. It has helped me in many ways, like connecting me to counseling, school, getting me lists, even cool gift cards. One big reason why I like the program is because they support your goals 100%. They got your back on things you want to accomplish. After I joined the program, I realized that they want you to become a better version of yourself.
Hello, everybody. Hope you like the video. Once again, this is Chevist Johnson, one of the violence intervention specialists here at UC Davis Wraparound program. And today I wanted to start off by kind of introducing you to how we introduce clients into our program, how we identify them, and kind of get them headed down the road to physical and mental recovery. So first of all, we are hospital employees of UC Davis, so we have access to all of our EMR charts. We come in every morning and we view those charts, and we have them broken down between our trauma departments as well as some of our orthopedic departments. And we've allowed also social workers and nurses to have access to our wraparound list that we've developed within EMR. And they're able to move patients over into our lists if they run into patients, especially like over the weekends and stuff when we may be not here on like a Sunday. But we come in every morning, we go through the list, we see which individuals fall into the parameters of our program, and then we discuss that as a team, how we would like to approach it, who has caseload availability, and who would just like to go over to the hospital. At times, one of us will go, sometimes two will go, and there have been some times when all three of us have had to go over to the hospital due to the amount of individuals over at the hospital at the time. But as we go over to the hospital to check in, our office is located a couple blocks away from the hospital, but we drive over to the hospital, and we like to get to the floors and meet up with the nurse who is taking care of the patient. And we kind of check in with them, see how their recovery has been going, see if they've had visitors, see if there's any pertinent information that they may want us to know, that they can provide for us, that can be a little bit more extensive than some of the social worker notes that we've read online in EMR. And then we just kind of go inside the room and kind of get bedside with the client and see how we can best meet the patient's needs. On our initial time when we go in, we usually try to be very relaxed. Obviously, we introduce who we are, but we really want to know how they're feeling mentally and physically. We want to know if they feel like they're being supported at the hospital, if they're getting the care they need, and if there's anything that we can do to kind of bridge that gap between them and the medical professionals to kind of be a voice for them. After that, we do briefly explain what our program is. Basically, we service individuals who are 13 to 26 who have been shot, stabbed, or assaulted and admitted into the hospital through the trauma department. And we mentor them for from 6 months up to a year. Our program is completely free, so they never have to worry about coming out of pocket for anything. We come alongside as mentors, trying to help them reach their goals. And as we set out a case plan for them with their goals, we reach out to different community partners that we've built partnerships with to kind of help them along that. So one thing about our partnerships is that we have partnerships both inside the hospital as well as outside the hospital. So like I said before, we work closely with our surgeons and our social workers. We do a lot of advocacy on behalf of our patients. And a lot of times we do a lot of education as well with our medical staff. So they can understand some of the mental mindsets that our patients are in, some of the environmental circumstances which may have them where they're at, and just try to help them really humanize our patients and not see them just as another person. Outside of that, we also, again, work with a lot of community agencies. One of our biggest partnerships here in Sacramento is called the Black Child Legacy Campaign, which was developed to decrease Black child deaths within the Sacramento region. There are 7 different departments that are set up in 7 different neighborhoods who have the highest rate of Black child death. And we sit on the MDT board on the CIL, which is a Community Incubator League, which is in Oak Park, which is where our hospital is located at. And it's serviced through the Greater Sacramento Urban League. And as we come to those MDT tables, we're able to meet with people from DHA, from probation, people who can help with job assistance, Job Corps, things of that nature. And we sit down and we can bring our cases to them to be able to kind of wrap around the patients that we have and kind of meet their needs. Also with that, we do a lot of things as trying to support them as the MDT team, and the Oak Park people are always supporting us with our clients. We try to do things like volunteer as basketball coach during the summer. We show up to events and kind of support them by tabling stuff for them and just being overall assistance to them out in the community. And we also, before COVID, we were doing a lot of peace walks, walking around the neighborhoods, knocking on doors, introducing ourselves, and just letting people know who we were, what organizations we belong to, and seeing if there was anything that we could do to kind of support them. With that, we've seen a lot of success, and we're looking to continue to build on those partnerships. And we think the Black Child Legacy Campaign has been an awesome partner for us. And we work hand in hand to make sure that we can service the clients, not just of Oak Park where we reside, but also Sacramento citywide.
Thank you, Chevist. I'm going to go ahead and speak a little bit more about some of our other partnerships that we have. One of those is with the Health Alliance for Violence Intervention, also known as the HVIP. So on top of our lived experience, we are connected to this network, and through this network, we are actually certified violence prevention professionals, which just gives us the ability to be experts in our field, be able to do the work and be best practices and be able to provide the best value of care for our clients. In this network, I'm part of the Empowering the Frontline Working Group. I'm part of the co-chair, which is a safe space for other VPPs to be a part of. We advocate for our profession nationally and locally. We share best practices. And again, we're just a safe space for other frontline workers to come together and just connect and not feel so alone in this work that can quite possibly be heavy at times. Within the hobby, we also have the Reimagining Public Safety Group, which Chevist is a part of, and their focus is to provide law enforcement policy changes within hospitals, hold those policies accountable, bring them to the forefront, educate other frontline workers on what those policies look like as well, so that when law enforcement is involved with any of our clients, there is knowledge there on how to support them while they're here within the hospital. And there's also the Mental Health Working Group, which Nerisha is a part of. And through that working group, there are also shared best practices and even challenges. There's also creative solutions and, talks on how to bypass natural barriers that come with counseling. So how can, mental health professionals really come and support clients out in the field? How can they truly give them access to counseling? What kind of terminology should be used when introducing a client to counseling, and so on. So we're part of that as well, and that's on a national level. Within our program, we also have a partnership with the Violence Prevention Research Program that's connected to UC Davis. Nicole Kravitzworth and Shawnee Bugs sit with our Wraparound team, and through our partnership with them, we've been able to develop the Wraparound research piece of our program. And so what that is we give out surveys every 3 months once a client has signed consent and is on board with our program. The surveys allow us to provide well-rounded support and conversations that revolve around their attitudes towards gun violence, perceived social supports, depression, PTSD, and additional just conversations that we get to have with them about their overall wellness. And because we give it to them every 3 months, we are able to really closely track their progress to see how they are overall doing, how is their wellness, how are they recovering from what's happened to them, and how they are moving forward or not. And again, that allows us to then, as violence intervention professionals, to come alongside them and connect them to the right resources and support that they need. On top of the research piece of it, we also want to connect them with other individuals that have lived through what they've gone through. And so we have a peer support group that we stopped a little bit because of COVID-19, but before we were actively meeting once a month with our clients, our caseloads. We were coming together to promote that peer support. And so in the last year, we also created a curriculum that's specific to survivors of community violence. We have modules within that curriculum that talk on mental health, physical health, self-care, relationships, social and personal safety. And all of these topics were topics that survivors have talked to us about, who have said, hey, I don't know how to move forward with my relationship, or how do I go into a place of self-care after I've been in survival mode for so long, how to take care of my wounds, or what's the importance of me going back to visit a primary care physician. And so this is how we were able to create those modules through the survivors in our program who really just said, hey, we have questions and we want to know what others are doing. So really exciting stuff within our program, and this is additional stuff that we do throughout our program to ensure that our clients get the most care.
Thank you, Esmeralda. So we're going to talk a little bit about just zoom in on how our time with the clients within those 12 months. And I'm going to start off even talking about rapport building, because it is an essential part of the work that we do, getting to know our patients from the time they come in the hospital. These patients have to be vulnerable with us. They're sharing, something that happened to them. And we also share parts of us to stay connected with them, to normalize the work that we're doing. And to give them more insight on the work, the role that we do, and how we will be providing support for that 12 months in our program. So we began building our rapport initially at the bedside, making it light and friendly as possible, but also coming in with the knowledge around, what this is going to look like, and acknowledging what they're experiencing. As we provide that support, that is happening post-discharge up to 12 months. So the moment they come in, like Chevist mentioned, we're doing that bedside. Once they're discharged, we are connecting with them. We exchange contact information in the hospital, so we can then have their contact, so we can do intake with them. And we meet with them in their community, wherever is comfortable for them. We'll go out and meet with them. We're going to do an intake with them, provide them with appropriate documents that will allow us to move forward and give us permission to stay connected with them and work with them in our program. Within that 12 months, we are creating a case plan with them. And within that case plan, we're going over things about like safety. Is it okay if they have an emergency? Can we reach out to them? We're talking about their goals that they have, things that they may have wanted to complete it prior to their injury. We're talking about immediate needs, things that they're needing, now. And that could be access to full resources. That can be housing resources. Anything under the sun that they're needing, we try our best to connect them with community resources. Also, part of that case management is having fun, exposing them to different things they may not have been exposed to. One thing we understand about our population we serve and the clients we're serving is that they are likely to have sustained another traumatic injury before this even happened. And they're also vulnerable to be involved in another one. And that's where our role come in as prevention specialists. So we want to expose them to museums that they may not never visited in the community, parks. We're going out to lunch with them because all these different things is supporting their overall recovery. And they have fun and they like it. So that's something that we really highlight in our program, just having that flexibility to be able to take them to lunch and, go to the movie theater or bowling. It allows them to, we're working with youth, so allow them to relive those youth experiences that they may not have been able to live. Also within that case plan, we are revisiting that case plan. So we are talking to them about some goals. We have some patients that say, hey, I want to get back into school. I want to finish my high school diploma. So we are revisiting that case plan every 3 months. And like Esmeralda said, the research component of things, they're taking a survey, and then we also utilize that time and space to say, hey, let's check on your case plan. How are your goals going? Is that still a goal? Do you want to reestablish a new goal? We just use that time to reconnect with them and see how they would like to move forward as far as their case plan. The way we check in with our clients is something that come up. We usually just have phone calls with them, home visits. We're very text friendly, so we're texting. We even have some clients, you know, nowadays we can FaceTime. So we get really creative when it comes to like our check-in process with them, but it's also light and it's friendly, accessible and easy to stay connected with them. Within our relationship as violent intervention specialists, we are also extending life skills to our patients. Showing them appropriate ways to communicate, setting those boundaries. Hey, don't call me 4 and 5 times. Like, that might not be a good fit and a good skill to have, just to, call people back to back, or to use certain language with some of our specialists. So we're extending those life skills with them and making sure that we be role models to them. We take pride in that and provide them feedback where we see fit. And so that's a huge component of our relationship, is extending those life skills, because it's absolutely necessary, and it's a part of their recovery as well as they become, see their self the version that they want to be. That's really important. Something else that we do is our role bridge the gap in many areas, and provide advocacy is one of our most important things that we do. And we provide advocacy, when you think about medical resources, we're extending that to them. Mental health resources, we're bridging that gap. Employment resources, housing, education, and so much more. Like Esmeralda mentioned earlier, and I am an associate marriage family therapist. And so we hone in on their mental health too, because that is a huge component of their recovery. And so I'm able to identify some of those symptoms that we notice from the moment they get to the hospital. We're checking in with them at that bedside, and we're noticing that sometimes they, PTSD symptoms are coming up. A lot of them have nightmares, stress. They're also impacted by other traumas such as homelessness before and even after their hospital stay. They worry about the future, and sometimes even hopelessness is showing up. So we're able to connect them with community resources, but also as specialists, and for me as an associate marriage and family therapist, provide them with some type of temporary support, emotional support, and skills to help them get through the next day. So those are some recurring things that we see. And lastly, I am a part of the HIV mental health working group, and it was mentioned earlier that we are constantly having conversations on how to better serve our population. We're able to connect and highlight some of the reoccurring themes that we see when it comes to our patients, and even accessing mental health services. Sometimes they're interested, sometimes they're not, but we constantly advocate for them to receive that support. And just as a violence intervention specialist, having a safe space to connect with other professionals and process our own experiences to make sure that we are showing up as the best versions of ourselves and taking care of ourselves as we do this line of work.
Thank you so much for that, Nerisha and Chevist. And Amy, before we hand it back to you, we do want to acknowledge Hillary Gonzalez. I know that she connected us to the Blueprints project, and she also was a huge contributor to our peer support curriculum. She's awesome. She really loves this work and has been a true supporter of our program. So we just wanted to highlight her. And I also want to wrap it up by saying that, throughout our entire 12 months with our clients, we see a lot of healing, a lot of liberation. We see the other side of healthcare and mental health. We see a lot of perseverance and resiliency, and it's really so sweet to see that resiliency is not just the benchmark for them, that they actually get to move forward with recovery, with their lives. And it's a huge honor for the three of us to do this work. Thank you for having us.
Thanks so much, all three of you. And thanks for opening, I know, my eyes and probably some other folks to what it is you all do, because we hear a lot about your program, often from Hillary, who really learned a lot from her experience there and has brought a lot of that into our work here at Bullet Points. So thank you very much. And I know we have a couple of questions in the chat. And before we get to those, we want to do the closing poll, which will again be very quick. So let's launch the poll. And if you have questions, go ahead and put them in the Q&A. Okay, great. Thanks everybody for participating in our polling. And now some questions. How many individuals do you all serve in a year at the Wraparound program?
So we come in contact with about 40 individuals every year that fit into our criteria. And about half of those we get enrolled. And then length of stay is just kind of depends on the individuals. Some actually advance before the end of the year. Some actually even just, we kind of lose contact, whether it's through incarceration or through homelessness or just, whatever happened to go. COVID obviously hit, and that put a big wrench in some of the things that we were doing. But we usually see about 40 patients a year that actually fit our criteria, and about half of those will actually enroll in our program.
Great, and that actually kind of segues into another question, which was, do patients typically agree to participate, or is there some hesitation, and what are those obstacles for the 20 that don't participate?
I would say we've noticed a lot of family dynamics play a part in this. So a lot of individuals who may have a good rapport with us as we're visiting with them in the hospital and stuff, if we see that they have a strong support system, a lot of times those individuals won't sign up for the program. And our assumption, at least, is that because they have such a strong support system, they feel like, oh, well, we have mom and grandma and maybe significant other, whoever it is that is supporting us, so we don't need the extra support. Versus when we run into individuals and they really don't have anybody in their corner, and they just kind of latch on to us really quickly. And then also, like I said, sometimes homelessness plays a part, and things of that nature kind of play a part in why individuals don't actually sign up.
Okay, great. Thank you. We got one question about someone who wants to start up a hospital-based intervention program, but they're starting from ground zero. How do you go about securing resources to implement the program, and where does a person even start if you don't have this and you want it where you work?
That's a really great question, and exciting to hear that others want to have this program at another hospital. So a couple of things that came to mind, at least within our program. We can definitely connect you to Kristy Adams, who is our program coordinator. Back in 2010, she actually launched Wraparound for the first time, and it did not launch off successfully. And so she has a lot of good stories that she can provide you with, a lot of insight and tips on the don'ts of starting a violence intervention program. And then in 2018, she relaunched this program again. So she has a wealth of information that she could be able to provide as far as in how to be resourceful, where to start within your local community. She can definitely provide a lot of insight on that. The other is within the Hobby Network as well. They actually do training for those who want to start hospital violence-based intervention programs, and kind of do a similar thing as Kristy would do as well, but more on a national level of what does it look like maybe within your city to look at statistics, how you can use that to help you with grant writing, how you can use that to get leverage within the hospital you're working with, how to find what we call a champion surgeon or medical team that's going to really help to bring this program to life within the institution that you're in. I know as well, Chevist and I, as well with Nerisha, we've actually had one-on-ones as well with folks who wanted to start hospital violence-based intervention programs. So we speak more on the frontline worker perspective and just, the hiring process. What kind of qualities do you want to look for? How caseload-wise, how many clients should you, have on your caseload? How to process the work. Vicarious trauma is a real thing in our line of work. So how do you take care of your staff? How do you, promote that as well? So we've definitely done those talks as well. And I could either, Amy, reply to the email and send over Kristy Adams' information. And then we can also connect you guys to the Hobby as well.
Great, thank you. The person who asked that question actually was anonymous. So if they want to email the Bullet Points email account, which you can find on our website, then send us an email and we'll put you in touch with Esmeralda and with Kristy Adams so that you can get some more information about that. I see that we're at time right now. So thank you very much for everybody for asking these great questions. And thanks to our panelists for coming to present about this really important work that you all do. And thank you for being out there and doing what you do. And if anyone else has further questions, feel free to reach out to us via the Bullet Points account and we can put you in touch with folks or answer questions yourself or send you resources. So thank you all for coming again. And once again, we will not be having a webinar in December, but look out for a follow-up email with this recording for this webinar and our January registration link. Okay, thanks everybody and happy holiday season coming up. Bye.
Bye-bye.